break 5 minutes. So the next topic is also a big topic. I'll do the first big topics up front, which is headaches. Now, just as asthma is a very, very prevalent problem, headaches are even more prevalent as a problem. And as part of your emergency medicine course, you're taking cardinal presentations. Cardinal presentations here at that you need to have an approach to because they're so common. منها chest pain, منها shortness of breath, منها headache, منها abdominal pain. And the point is to say, these are one of the most common reasons you'll see patients, Aslan, because they'll have this complaint. So you need to have a very effective approach to this presentation to know what assessment you need to do, to know when you should worry, when you shouldn't worry. So I'm going to talk about the categorization of headaches. I'm going to talk about the characteristics and burden of disease a bit, and I emphasize the screening and for secondary types of headaches, which is emergency department specific. I'm going to talk about the common headache disorders.
Doctor,
Let's talk about the burden.
can you go a bit slower?
Sure. I'm going to go a bit slower, but not much because you don't have that much time.
Okay.
So the burden of disease. Headache is obviously very common. I mean, and a lot of people visit emergency departments for headaches. It's one of the most common reasons, and it's probably anywhere between the fourth or third most common reasons patients will come to the emergency department as a complaint, as a primary complaint. So there's some evidence about headaches, and 1 out of every 4 or 5 patients say they've had a significant or severe headache in the past year when it comes to the Saudi population. So it's obviously, and I think everyone here at some point has had a headache. It's a very common symptom. Some of us have it intermittently, and it's very benign when we manage it. And some of us, it's debilitating, and it's it affects our livelihoods, the way we function. So headache, also known as cephalgia, it's a symptom of pain, and it's important to understand this. I think the most important thing is to understand is that headache means pain in the head area. That's all that it means. And it's one of the most common presentations in primary care practice. And it's important, again, to understand that brain actually doesn't feel pain. People are convinced that when they're having headache, something inside their brain is wrong. But the brain actually doesn't have any pain receptors in it. And in fact, you'll see a lot of patients come in with strokes or hemorrhage, intracerebral hemorrhage, and they have no pain. They don't complain about pain. They may complain about a headache, they may or may not, but generally it's not painful. And the pain is related to more of the stretching of the meninges, etc. But the brain itself doesn't feel pain. Most of the pain is actually from the structures around the brain itself. So you have to consider that when you're seeing some patient with a headache, where is the pain actually coming from? And I think that's a big issue with how we address these patients, is that we don't actually consider where the pain is actually originating from. And it can come from anything from the vessels to the teeth to the soft tissue, can be referred from the neck. So it can be nowhere near the brain itself or the head itself, where the pain or the issue itself is. So how do we classify headaches? And this is important. Generally, the gross classification would classify them into primary headaches, secondary headaches, and cranial neuralgias. These are the common causes of headaches per se. And this classification is important because it illustrates benign causes versus more serious causes versus chronic neuropathic causes. Benign primary headaches is the most common cause of headaches, and this is what we see as the tension, the migraine, cluster. There's many other types as well. And these are real diseases that have some of them have very debilitating, but for the most part, they're not dangerous. And then secondary headaches, which are headaches caused by other systemic or local processes, and we'll talk about those. And then the cranial neuralgias are like chronic inflammatory or abnormal, abnormal, basically, pain response through the nerves themselves. That happens through multiple mechanisms, which we're not going to talk about. So the primary headache, most headaches are primary headaches. It's important to understand that. Mostly, the disease actually it has an age group which is prevalent, and it's mostly the 20s to the 40s. This is where you'll see it peak. Again, most common types is from either tension or migraine, depends where you read it. There are many other types of primary headaches. We just don't focus on them, but if you study, neurology or primary healthcare, you will see that there are many types of headaches, and they have different presentations, different aggregating and relieving factors, and different response to the therapy. So it's just important to know that they exist, which I'm not going to talk about them. But the point is to know you need to know what a primary headache looks like to know what a secondary headache looks like. That's a big important part of it. Anyways, so in the emergency department, particularly, we're concerned about the secondary headaches. And those are usually due to, like I said, systemic or underlying structural cause. And the secondary headaches are basically also grouped into systemic sort of approach to a secondary headache. We say headaches that are associated with head trauma. These are concussive headaches. Usually after a head trauma, we'll see them. Whether there's a bleed or not is not the point. A lot of patients can have head trauma, and most of them will have no abnormality on CT or MRI, but they will develop headaches with that. That's a form of headaches. That's a secondary tone of headaches. And then headaches due to vascular abnormalities, as a, which we, some of them are severely life-threatening, such as subarachnoid hemorrhage, and acute strokes can cause headaches. Not often. Most often, they actually just don't actually cause anything other than a focal deficit or deficits. But some of them can come in with headaches. Some vascular malformations prior to rupturing can cause headaches, chronic headaches. Arthritis or vasculitis can also cause headaches. Common one being is giant cell arthritis, something we have to screen for. People will say that I have a headache from hypertension. It's not clear if actually hypertension can cause headaches. It's probably more so that if you have a headache, then you're going to be hypertensive because you're in pain. Because hypertension is known as a silent killer. Because most people have hypertension just don't know they have it until they have a stroke or they have a heart attack or they have, or they have renal failure. So for the most part, hypertension is not symptomatic. It's asymptomatic until the disease happens from it. Then headaches from intravascular disorders such as intracranial hypertension, pseudotumor cerebri, which we see in obese African descent women, more specifically. We see it from intracranial infections, obviously, such as meningitis, encephalitis, brain abscess. We see it from actually CSF, commonly like in post-LP patients, or lumbar puncture patients. They have CSF leaks, and some of those can be spontaneous as well. These are all cause headaches. We see headaches with substance, and this is quite prevalent as well. Hassan, Ramadan, شوف الناس, everyone يقول لك أنا مصدع. Well, it's because you're in withdrawal, mostly from caffeine and stimulants, and nicotine. These are obviously, and then we see it also from excess use. People use a lot of stimulants can also get headaches with a rebound effect. And then we see it from systemic infections. When you get a cold or a viral infection, you can have a headache as part of it. Bacterial or viral, either wise, and you can get it from metabolic disorders, but this is an important one. People with hypoxia can come in with a headache. People with CO2 narcosis come in a headache. We often see people with obstructive sleep apnea. They're one of their biggest complaints is that I have headaches when I wake up in the morning, and it's usually from the CO2 retention and the hypoxia. Hypoglycemia, one of the earlier symptoms, can be headaches as well. And then an important one is also like carbon monoxide, which is it's metabolic. I'd say more. It's toxicological / metabolic. The earliest complaint is a headache. It causes headaches primarily and usually it's presentation. And then headache associated with anything, any musculoskeletal or bone issue, mastoiditis, dental infections, etc., which will cause pain. And then we do see psychiatric headaches. We see people with generalized anxiety disorder, panic attacks. Part of the presentation is a headache that's related to their state of mind or their mood. So if you address that, their headaches will actually get better. So some of them are quite benign, as you can see. Some of them are quite life-threatening. And then the cranial neuralgias we talked about are a different type on their own, but they're quite debilitating and can be quite severe, and there's multiple reasons they happen. So sometimes you see people with that in the emergency department. So you just need to know they exist, and they have specific treatment algorithms. So how do we approach someone with a headache? Just like I'm going to ask you how to approach someone with abdominal pain or chest pain, you need to know approach someone with a headache. I think the mainstay, aham shay that you focus on when someone with a headache is to be able to assess, is this a primary headache disorder or a secondary headache disorder? And this is based mostly on history and then on the physical exam. But in the emergency department, the focus to rule out or at least say risk stratify the patient that this is not a secondary headache and likely a primary headache. So first question is always going to be someone with a headache is this a new or old headache? Patients, like I said, with primary headache disorders are usually chronic and recurrent, but the most part, people with tension, migraines, etc. They've had this in the past, for the most part. So you have to ask them, usually have headaches like this, or is this different? Usually old headaches are primary headaches. Sometimes the first presentation of the migraine or the first presentation of tension headache, but you can figure that out with the presentation itself. But new onset headaches are in the emergency department are definitely more concerning for secondary headaches, because most primary headaches are an outpatient treated disease or something that the patient treats at home, etc. And another second important question is, what age did the headache begin in? Like I said, primary headaches start at specific ages, anywhere from your 20s to your 40s and 50s. If you have headaches at a very young age or at a very old age, you have to start worrying about more serious causes. And one of the red flags of headaches, which we'll say is where imaging is indicated, is if you have new onset headache at above the age of 50. Because at that point, the likelihood that it's a primary headache becomes quite lower, and the likelihood that it's a serious secondary cause becomes quite high. So the associated symptoms, that's important, because we know what primary headaches look like, right? Or we should know what they look like. If the associated symptoms are discordant with the primary headache, then we have to think about a serious secondary cause. Or if they are serious associated symptom, then it's definitely not a primary headache. So we know that like cluster headaches come in with lacrimation, nasal congestion, rhinorrhea. Migraines come with an aura. They come in with photopsias, abnormal sensation, abnormal smells, and even some of migraines can cause hemiplegia and like stroke-like symptoms. But usually that's a chronic recurrent thing. But secondary headaches come in with things that are never. They come with things like diplopia or change of vision, or neck stiffness, or confusion, or a rash. That's obviously not the primary headache, right? That fever, if they have new onset weakness with it, or balance disturbance, that's not a primary headache. That's a secondary headache. So the symptoms are very important, and it's very important when you're taking history to ask about these questions, these screening questions for secondary headaches. Because this is the important thing, which just delineates, is this dangerous or not. So onset and progression, it's really basic questions, but people fail to do that. You have to ask them, when did this start? How bad did it get? What kind of pain is it? What makes it better? What makes it worse? It's just a pain question. Sudden onset headaches that are rapidly progressive, they're very concerning, this is what we call a thunderclap headache. People say thunderclap, people imagine that it's a snap of the fingers. That's not what a thunderclap headache is. Thunderclap headache is a rapidly progressive headache over an hour. It's worse than baseline headaches. That's what a thunderclap. And usually that's associated with subarachnoid hemorrhages, which are, if untreated, have almost 100% mortality. Vascular malformations, CVAs, the mass lesions, and sometimes cluster headaches can be that severe as well. But those are more rare to see. So that's about severity and quality. Like a tension headache is usually mild to moderate, not too bad, and usually compressive in nature, whereas clusters are severe, debilitating. Coming clusters, migraines are usually moderate to severe. So you have to understand the disease they have to know if this is concerning or not concerning. And the frequency, again, you have to understand the patterns. We know what cluster headaches look like, how often they have. Migraines happen, over a period of time. These have a prodrome, and then they have a period of pain, and then they have a period of resolution. Tension headaches usually are short-acting, very short, responding well to pain with specific symptoms. And cluster headaches are quite severe and happening only seasonally. They don't happen outside of those seasons usually. Location and radiation, again, very important. You expect a cluster headache to act in a steroid, usually unilateral behind the eye, doesn't go anywhere else. A tension headache is a band-like, compressive across the head. Migraines is usually mostly unilateral, compressive in nature, but may become both all the head. Secondary causes that can be concerning, like if they have tenderness with that or pain along the temporal area, the headache with someone who has risk factors, and you think about more serious things like a vasculitis, you have eye pain associated specifically, then this might be due to acute ankylosing glaucoma causing a headache, which is something we see in the emergency department. They come in and tell you, I have a headache, and then if you ask them, they'll say, yeah, my vision is blurred. But if you're more specific, they'll say, oh no, it's one eye actually that's blurred, and then if you check, it is actually the eye that's the cause of the pain, and this is vision threatening if not treated. So history is important in these patients, right? patients who have dangerous causes of secondary headaches usually have risk factors for them. So if they've had history of meningitis, they're immune suppressed, they have HIV, they've had they have malignancy, active malignancy, or they've had history of of stroke or vascular malformation. These are higher risk patients, obviously. Sometimes the risk history will tell you for benign causes, if they had the URTI, etc. This is reassuring. If they have history of hypertension, that puts them at high risk for secondary causes. If they're immune suppressed with steroids, obviously that puts them at risk for infections, etc. If they had a recent instrumentation or head trauma. So the history is very important. Obviously, if they're taking blood thinners, it's again important. Medication history is very important in patients with headache presentation. What do they use? What are the substances they use? What are they not using? Because the medications put them at risk, cause the headaches themselves, and put them at risk for secondary headaches. So again, trauma and recent instrumentation, like we just talked about. And again, things like that might not be irrelevant, but you didn't ask them about. Do they have ear pain? Do they have teeth pain? Do they have any instrumentation, something down to their neck, any neck pain? Because this could be the cause of their headache. And they might not be able. You have to be able to ask those questions. So triggers. We know that primary headaches have specific triggers. So you have to ask about what makes things worse and what makes things better. We know things like migrainous headaches are worse during menstruation. We know that it's triggered by voice, noise and lights make it worse. So especially things like migrainous headaches, which are quite debilitating, its triggers are very important. Family history, usually again, things like migraines have a strong pattern of family history, so you should ask about that. Psychosocial history, again, substance use, occupational exposure, is like carbon monoxide is a bit important one. Psychological history is important as well. Are they, this is acute stress associated? This always happens when they have an exam, etc. And what's their sleep pattern? Because obviously things like migrainous headaches and tension headaches get worse with poor sleep. So on exam, how do you approach these patients? When I ask you to approach a patient, you always tell me, how do they look? Do they look well? Do they not look well? Do they look sick? And then you comment about their appearance, which is how they look, and then their vital signs. Always comment about the vital signs. Someone who has a headache and has a blood pressure of like 220 is quite concerning, or someone who has a headache and a temperature that's quite concerning as well. So the vital signs are important. Or there's someone who has a headache and is hypoxic, that's also very important. Then they need a cardiovascular, at least a rudimentary cardiovascular exam, because like I said, a lot of these things can be cardiovascular in nature. ENT exam is important in these patients as well, because that could be the primary cause. Part of the exam is facial palpation for obvious reasons, and fundoscopy for patients who have ophthalmological complaints. If they're complaining about their eye, then they need a full ophthalmological assessment, including fundoscopy to look for glaucoma. And then this is key. If somebody comes in with a headache, they need a full neurological assessment. It's just sort of like someone coming in with an abdominal pain and not getting an abdominal exam. It's basic part of the assessment. If you don't do a full neurological assessment, there's no point in you seeing that patient. You've done nothing useful, basically. So in the emergency department, we're not neurologists. We don't need that level of detail, but we need at least enough information to know if there's any major abnormality in the neurological system. So they need a comment about the mental status, the level of consciousness. They need the cranial nerve testing. Rudimentarily, you need to comment about all the cranial nerves. You need to talk about motor strength in all extremities. We do at least basic reflexes. And you talk about like abdominal reflexes. Usually we just do the Babitsky's. Gross sensation, we don't need to do fine motor sensation or vibration sensation. Just do gross. Do you feel this is the same as this? Cerebellar testing is important. To know if there's any cerebral dysfunction. Then we need to comment about the gait. And also part of the assessment is comment about neck stiffness and meningeal signs. So this is a basic neurological assessment in the emergency department. This you need to do with anyone with a headache or any neurological symptoms per se. So red flags. So you'll hear this term used in back pain. You hear this used in headache. You hear maybe in other things. I'm not sure. But red flags are historical or physical presentations in patients with headaches that suggest this patient needs advanced imaging. And advanced imaging in the emergency department is mostly non-contrasted CT of the brain. Obviously, most patients who come to the emergency department don't need imaging. They have exacerbation of their chronic disease. They have tension, migraine, headaches. There's no point in getting a CT. It's just unnecessary exposure to radiation with no findings. So we say that patients with a headache beginning after the age of 50, that's concerning. If you have a new onset headache, that's suggestive of mass lesions or giant cell arteritis. If you have sudden, progressive, rapid headache, which you talked about, thunderclap headache. Usually that needs a CT and a CT angiography to look at the vessel itself. Interactable headaches. So even if you have chronic headaches, but you have no headache that's not going away for 3, 4, 5 days, then you need a CT because sometimes it's something else like a mass lesion or a hematoma, or a deep vein or a venous sinus thrombosis, like a thrombosis in the veins of the brain. New onset headache, patients with significant risk factors like HIV, immune suppression, anticoagulation, active cancer, because that suggests that there's a secondary cause. So these patients need imaging. You have systemic illness and then you have a headache. That's a concerning sign. You should, if you have signs of meningitis and then you have obviously headache with that, or you have signs of sepsis and a headache, you should get imaging because there may be associated infection in the brain. Focal neurological symptoms, that seems quite obvious. If you have a headache and you have weakness or slurring of speech, you need the CT to rule out stroke or intracranial hemorrhage or a mass lesion. Again, abnormal vision can be an indication for imaging if they have papilloedema, suggestive of a mass lesion, headache with subsequent to head trauma. Not all patients who have headaches post traumatic injury to the brain need imaging. We have rules that say who needs imaging of the brain. Canadian CT head rules, which you'll see in the emergency department. They'll talk to you about. Maybe they'll mention to you because a lot of people have concussions, which don't benefit from CTs because they don't show you anything. But a lot of patients do to rule out bleeding, obviously. Headaches triggered by specific things like exertional, new onset cough, etc., can be suggestive of a intracranial hemorrhage. So, do patients with headaches need testing? Just like asthmatics, most patients with headaches, because it's so common and it's mostly benign, there's no point in testing these patients. Testing doesn't help you identify anything. So we do it to look for secondary causes. If you're thinking that this is not a primary headache, then you would do testing. And it has to be focused on what you think the underlying cause is. If you think this headache is due to infectious process, a central or systemic process, then you'll do CBC. If you think this is due to metabolic cause, then you'll do renal profile with that. If you think this headache is due to a toxicological cause, then you can also do testing for that. Who needs imaging? Most patients with headaches don't need imaging in the emergency department because most of them are primary headaches. But the test of choice for imaging is a non-contrast CT. MRI is actually a better test, but it's just not readily available, difficult to read, and it takes time to do. So that's usually done as an outpatient, other than specific indications such as vasculitis, which we can't see on a CT. And usually this is done by a neurologist as an outpatient. You can miss things like cancer or like metastases with a CT early on. Even a lot of strokes can be missed. So CT is not as sensitive. MRI is a lot more sensitive than a CT for secondary headaches. Lumbar puncture is also part of the testing. We use it to identify, obviously, infections. And we'll also use it, that's how we measure the pressure. If you have increased intracranial pressure or even decreased intracranial pressure, we can measure it with the lumbar puncture of the CSF. And we look for other specific diseases as well, such as TB, etc. And encephalitis is also through lumbar puncture. So it can be very useful in secondary causes. Tonometry, like I said about, which is measuring the pressure of the eye, that's a way to diagnose angular glaucoma. So sometimes that's part of the testing if there's visual complaints in an older patient. So let's talk about primary headaches. If you don't understand primary headaches, then you don't know what secondary headache looks like. So primary headaches are obviously the common headache disorders. Migraine is the most common, maybe second most common one. Chronic headaches, usually moderate to severe. Most often unilateral can become bilateral. They're usually associated with its aura or without aura, but there's usually some visual symptoms associated with that. It's most common in women. A strong genetic predisposition is usually seen in families. Period of build-up over a few hours, and then it's usually aggravated by movement, etc. Why people have migraine? Multiple theories, but we do know that there are risk factors that the precipitants such as stress, hormonal changes, of course, sleep, dietary intake. So it's important for people with migraines to actually keep a tab of what precipitates their migraines. So there's many theories. The most probably the most accepted theory is abnormal depolarization of the brain. I'm not going to get into that. So what does symptoms and signs of migraine look like? Throbbing pulse-style headache, severe in nature. You can read this yourself later. Associated with neurological symptoms are usually some nausea, vomiting, and GI symptoms associated. Photophobia. Some of them can have some significant neurological symptoms with it, such as aphasia, hyperesis, confusion, and numbness. But usually that's a diagnosis of exclusion. You have phases. It's more. These are sort of like the visual abnormalities you'll see in migraines. There's a diagnostic criteria for migraines with and without aura, and the diagnostic criteria are important because it helps us study the disease and helps us monitor the disease. But also, you see that the diagnostic criteria always say not better accounted for by any other disease. So that's what they're for. And we're not going to ask you about the diagnostic criteria. You just need to understand they exist, and that's how we kind of diagnose and classify it. So there's some very dangerous things that look like migraines, such as temporal arteritis, meningitis, subparietal hemorrhage, and some more benign cluster headaches and acute glaucoma. Maybe not as dangerous. So how do we treat migraines? Well, mostly it's avoidance of triggers, just like the asthma. There are acute medications as well with different evidence. The triptan, what you see for the emergency department, mostly we use is an antidopaminergic and metoclopramide is the mainstay of treatment. Paracetamol works quite well. NSAIDs work very well as well for these patients. There are medications that are used as prophylactic therapy, such as the triptans and ergotamines. These are medications you take. Some people have very severe migraines, so we take these medications to prevent migraines from happening. They even use anticonvulsants. They have some protective effects for migraines. So you see someone on like carbamazepine, they might not have seizures, but they might have chronic headaches, and they take the carbamazepine to protect them from the headaches. So it's important to understand they have severe headaches. Mostly for the emergency department, we use the metoclopramide, antidopaminergic agent. It's quite effective as an anti-nausea medication and helps them with pain itself. Like I said, sometimes you have prophylaxis. Some patients with migraines will get steroids. There's some more growing evidence for that. Definitely, if you have a status migrainosa, which is a migraine lasting more than 3 days, and you do benefit from the steroids. And people are more willing to give it earlier on now, so you won't have a relapse of your headache. Tension headaches, again, probably the most common type. I think everyone suffers from this. It's basically usually it's mostly stress associated with some psychological or physical stress. Again, women more than men. Anyways, I'm not going to talk about the subtypes. There's a criteria for it to say this is stress headache, tension headache, sorry. Mostly thought to be to abnormal muscle contractions. And there's clear triggers to it. How do we treat stress, tension headaches? Well, mostly it's avoidance of triggers, and it's mostly psychological, actually, more than anything else. Avoidance of behavioral changes in your lifestyle, avoidance of triggers, etc. There are medications as well to help, just like in the migraines, with different evidence. Cluster headaches, we like talking about them, although they're quite uncommon. They're characterized by recurrent severe headaches, almost exclusively. You do see it in women, but it's very rare. It's a male disease, usually in young males. It's quite debilitating as far as the disease. We don't actually know what causes it, but we know that there's some familial association, and there's seasonality. There's probably some exposure element to it. So they come in with severe, debilitating headaches, and they always have some autonomic changes as well associated with it. It's called clusters because it happens in clusters during a period of time, like during the season when it's happening. And they'll have to come back to the emergency department multiple times during that period because they're in debilitating pain. There's always an autonomic symptom, like I said, like drooping of the eyelid, pupil constriction, abnormal lacrimation, and injection of the cornea. Anyways, also what's interesting is how they respond to treatment. For some reason, they respond to oxygen therapy quite well. We don't know why that is either. That when you give them high amounts of oxygen via nasal cannula, the symptoms improve, and that's something they can't do at home, obviously, because they don't have an oxygen tank sitting at home. There's specific medications to abort the clusters, and there's also prophylactic medication. I'm not going to talk about. So this is sort of a summary of the primary headache disorders, how they look like, their severity, and how we treat them. Sort of how they look like. as per patient description. So some take-home points for the migraines. The most important thing about headaches is that they are chronic. If they're acute, then you should be more worried, and you have to figure that out on history. You need to know if this is new or old headache when you're asking the patient these questions. If the patient tells us a rapidly progressive, severe onset headache that I hadn't had before, this definitely warrants like a more invasive investigation or more aggressive investigation. Post-traumatic headaches have to have autonomic dysfunction as part of their criteria. And just remember that patients with migraine headaches a lot of it is environmental and trigger based. So they need to have diaries and just to say what's the cause of your headache and what's making things better or worse for you, so they can avoid them, to avoid these migraine to exacerbations of their headache. I think that's it. That's a lot of information, I know. أنا مدرك. عندكم أي أسئلة؟
Okay,
headache?
doctor.
Yeah. Sure. Let's take